So I'm Dr. Halasa, the founder of Chronic Disease Prevention Management Centers, and today we're going to talk about the effect of Losartan on cartilage and possibly the anti-fibrotic effect of Losartan in managing fibrotic disease in general. And let's get so please invite people because I'm going to, I already removed the box, right? And let's see here, slideshow. And from the beginning. Okay. I think it's clear here, okay? So let's start with looking for using angiotensin 2 receptor type 1 blockade, which is Losartan, to manage osteoarthritis. And we know that the cartilage, the articular cartilage, is mainly composed of chondrocytes and extracellular matrix, which consists of type 2 collagen and proteoglycans. And we know it is non-vascular tissue with minimal mitotic activities. So when we get injured, or those cartilage get injured, it's hard to, they're very hard, it's very hard to be replaced because of their limited capacity for self-repair. Although most cartilage defects are asymptomatic, yes, maybe the beginning, but with time and because of progression of this defect and the degeneration effect, definitely it can lead to osteoarthritis, and it can impact the patient's daily activities and quality of life, right? And so all those sportmen, sportwomen, especially of those sport that leads to injury in the joints, like football and soccer game and all those, it may lead to early onset of osteoarthritis because of the damage of this cartilage and lack or the limited capacity for self-repair. And we know why, because they are avascular or non-vascular, and they don't have that regenerative capacity like liver, for example. Liver tissue, if you take them out, you take even 1/3 of the liver, the remaining of the liver will replace the whole liver. But in cartilage, we have a hard time they have a hard time to be replaced or heal after they get injured. And once they get injured, that injury stimulate the progression of further damage of the cartilage in the form of the osteoarthritis. So for osteoarthritis, conservative treatments such as anti-inflammatory drugs, that's what we're doing. We're giving NSAID, possibly to reduce the inflammation, right, to suppress the inflammation. Or we use cortisone, which is immune suppression. We're using hyaluronic acid. That's the mainstream medicine what we're using. And maybe it will be benefit in the early stage, but of course, in the late stage, I think those drugs will help, and we end up doing what we call a replacement of the joint or resurfacing it. And so we don't have really a treatment option for repairing cartilage, right? And preventing the progression of osteoarthritis. All we're doing is more symptomatic relief, maybe decreasing the inflammation, pain relief, but we don't have a solution to slow the progression of the degeneration of cartilage. We may propose that stem cells and platelets may help to slow the progression of the cartilage biologically. But is it that effective? Really not. I don't see that we get complete replacement of cartilage by stem cells and PRP, but we increase the lubrication, yes, we increase the regeneration of the synovial fluid, and possibly that explain the lubrication itself would help to relieve the pain from the biologics. But using Losartan is one thing that we can do that may slow the progression of the degeneration of the cartilage. And so here we are proposing that the biological research that has revealed several candidates for osteoarthritis treatments and prevention, including angiotensin 2 antagonist, which is Losartan. I mean, I'm with using PRP, especially if you have the PRP and you prepare the platelets nanoparticle from the PRP, and then you load them with Losartan, with methylene blue, with dihexa, with possibly NAC, and many other peptides. If you want to add, you can add small dose of hydrocortisone. Maybe this will be the solution where we combine biologics, platelets, and maybe even stem cells. You can go ahead with stem cells, fat stem cells, and sonicate it, turn it into nanoparticles where you can clock those drugs. And why we're clocking them? So they can stay longer. Because if you put Losartan there in the joint, will not stay longer there. That's one of the things. So you need to put them into vesicles or into wrap them into membranes so you can have that slow release and more effect from that comes up from the Losartan. So that's mandating us in order to have an effective injection into the joints to treat osteoarthritis. I think we need to consider doing PMP, platelets nanoparticle, and load them with Losartan, with NAC, with methylene blue, with peptide, like as I mentioned, there's a new peptide that we're going to talk about, and maybe next week. It's a piece of melanocyte stimulating hormone. It's called KVP. Dr. Patel, she mentioned it last time we had a conversation on the phone. So we're going to talk about it. And yes, they are all inhibitors of interleukin 17, and they are immune modulators. So different between immune modulator and immune suppression of the cortisone, that the immune modulator does inhibit the inflammation that's causing the problem, because there's three kinds of inflammation. We talked about it before. We know that there's Th17 inflammation, Th1 inflammation, and there's Th2. Mainly osteoarthritis caused by Th17 inflammation, mediated inflammation. And we know that angiotensin 2, they have two receptors, right? Angiotensin 2 type 1 receptor and angiotensin 2 type 2 receptors. The Losartan doesn't have the angiotensin 2 type 1 receptor, right? And we know that the signaling of angiotensin 2 type 1 receptor are the one who's causing the inflammation and the fibrosis and the apoptosis. And how they do that, the angiotensin 2 type 1 receptor, when they attach to angiotensin 2, they signal in the cell the expression of transforming growth factor beta, interleukin 6, interleukin 17, right? And all those cytokines do stimulate fibrosis. In the joints, we have hyaline cartilage. It's there, right? That's mainly the hyaline cartilage is covering and forming the disc of the joint, right? But when we have this degeneration process because of the mechanical injury, and we have inflammation, and we have this angiotensin, of course, angiotensin 2 there, where it will signal the transforming growth factor inside the joints, and a transforming growth factor will stimulate the differentiation of those cartilage cells into fibrocartilage instead of hyaline cartilage. So you will see that the disc is converting into fibrocartilage, and the fibrocartilage does not have that smooth surface that you need. So and it's easily can be destroyed by the mechanical injury. And that's one of the problems that we have in osteoarthritis, where the hyaline cartilage is being transformed into fibrocartilage, and the fibrocartilage cannot handle the mechanical injury, so they get destroyed, and the patient ends up with bone on bone. So if we can inhibit the angiotensin 2 signaling for the angiotensin 2 type 1 receptor by Losartans, we can inhibit the expression and the action of this transforming growth factor beta along with interleukin 6 and 17. So while there are scattered studies reporting on various transforming growth factor inhibitors. There's many of them, and those are non-FDA approved. They are only in the lab, right? Some of them are antibodies against transforming growth factor beta 1, and we call them cytokine blockades. They are there, but they are not as effective as Losartan as an antifibrotic. So all those drugs, those are antibodies, will not be as effective as Losartan. And definitely, we are using those inhibitor of transforming growth factor beta in managing cancer. Do you know why? Because the tumor microenvironment consists of the cancer association fibroblast, which causing the fibrosis, right? And the fibrosis is restricting and pressing over the blood vessels, preventing the lymphocytes from infiltrating the cancer and destroying the cancer. So it's hindering the immune attack against the cancer. You know, when you see those cancers, they get a little bit harder and fibrotic, and they're squeezing those blood vessels, preventing the infiltration of the white blood cells and the lymphocyte and cytotoxic T cells to kill the cancer. So the fibrosis is not good in cancer tissue. It changed the tumor microenvironment in the favor of cancer, right? It protects them from the infiltration of the white blood cells by squeezing those blood vessels. And so we are using the transforming growth factor blockades, including Losartan, which is that's something I will definitely entertain to use Losartan, but we have antibodies and we have other drugs, but the best one is up to now is Losartan. So if you want to manage cancer, load your chemotherapy and your photodynamic drug and chemotherapy drug with Losartan. So you can break down the fibrotic tissue, allowing the chemotherapy and the photodynamic therapy drugs to reach and infiltrate into the cancer cells, and then allow also the white blood cells and the lymphocytes to infiltrate the cancer cells or infiltrate the cancer tissue and destroy the cancer cells. Okay, so there are few reported evaluating the effect of these drugs on articular cartilage, making the Losartan the most common transforming growth factor beta inhibitor in the articular cartilage. But again, Losartan is not inhibiting just the expression and action of transforming growth factor, but also the interleukin 6 and interleukin 17. So it inhibits the polarization of the and the inflammation of the Th17 mediated. So while it has been established that transforming growth factor beta is essential for homeostasis of articular cartilage, so you need to have certain amount of transforming growth factor because it does stimulate the proliferation of the cartilage cells in general. But too much of it, it will differentiate them into fibrocartilage instead of hyaline cartilage. So you need some, but not a lot. Once you have a lot, then this will differentiate the cartilage cells into fibrocartilage. So transforming growth factor beta has also been found to be overproduced in osteoarthritis joint. And we find out intra-articular injection, if we inject the transforming growth factor in the joint, it can induce osteoarthrosis. Why? We understood why. Why? Because it turns the hyaline cartilage into fibrocartilage. We know the fibrocartilage is rough, and they are not suitable for handling the mechanical pressure of those joints, right? The joints like the knee joints, all those synovial joints that we know, it's better to be hyaline cartilage, not fibrocartilage. And previous study have shown that osteoarthritis can induce in mice through inhibition of the interaction between transforming growth factor beta and transforming growth factor receptor, which is the inhibition of angiotensin 2 type 1 receptor inhibition that's signaling. It will inhibit the expression of the transforming growth factor beta, but also inhibit the signaling of transforming growth factor beta, which is binding to the receptor of the transforming growth factor beta. So the renin-angiotensin system, we know it's a major endocrine system. We thought renin-angiotensin system is only system for blood pressure, right? That's what we know before, and we are giving Losartan to treat patient with hypertension. Now we know that this system is not just involved in controlling the blood pressure, but also it's immune modulator. And we understood from even from COVID-19 that the spike protein does inhibit the angiotensin or the ACE2 receptors, which include angiotensin 2 type 2 receptor, allowing over signaling and over signaling of angiotensin 2 type 1 receptors, and that leads to expression of an overproduction of interleukin 6 and transforming growth factor and beta and interleukin 17. So we are blocking the inflammatory side of the renin-angiotensin system. I think we talked about that. We talked about that when we talking about the pathophysiology of COVID. We know that renin-angiotensin system and its key molecule angiotensin 2 function in the body by binding to angiotensin 2 type 1 receptor. Okay, it does bind to 2 type 1 receptor and type 2, but the fibrotic effect and the Th17 inflammation happen when the angiotensin 2 combine with angiotensin 2 type 1 receptor. If they combine with angiotensin 2 type 2 and ACE2, then it's completely opposite. You will end up with anti-fibrotic and anti-apoptotic and anti-inflammatory and vasodilation. Okay, but when it's combined to angiotensin 2 type 1, Losartan does not combine to angiotensin 2 type 2. It's only combining to angiotensin 2 type 1 receptor. It's very important to recognize that. Okay, that Losartan does inhibit the inflammatory, the fibrotic arm of the renin-angiotensin system, not angiotensin 2 type 2. And so it has been reported that angiotensin 2 induces inflammation when it's combined with angiotensin 2 type 1 receptor. So activation and what is the signaling that's happening inside this receptor when the angiotensin 2 combined with angiotensin 2 type 1 receptor? You will have activation of the NFK beta, and NFK beta, we know it will express free radicals. They will express pro-oxidant enzyme, and you have a lot of free radicals. And if it's constant stimulation, you will end up with pathological amount of free radical that will trigger the inflammation. It also stimulates expression of interleukin 1b, and we know that will cause general inflammation. And then it also expresses the interleukin 6, and interleukin 6 will induce the polarization of the immune system to Th17 inflammation. Then you will have expression of interleukin 17, and also it expresses the production of transforming growth factor beta, right? And so it expresses tumor necrotic factor, and it will express the expression of transforming growth factor beta, and it will definitely induce tissue fibrosis through activation of transforming growth factor beta 1, but also by activation of interleukin 6 expression and signaling and interleukin 17. So those are 3 cytokines that involve in stimulating the fibroblast and formation of the fibrosis, or differentiation of the cartilage cells into fibrocartilage. So angiotensin 2 receptor have been reported to be expressed in the chondrocytes, right? It's everywhere, but also in chondrocytes. And it has recently been demonstrated that the major components of the RAS, including angiotensin 2 receptor, are involved in the pathogenesis of osteoarthritis. So now we understood that renin-angiotensin system is involved in the pathophysiology of the osteoarthritis. The same thing we explained how angiotensin or renin-angiotensin system involved in pathophysiology of COVID-19 and post-COVID-19, because in COVID-19, post-COVID-19, we will also see some fibrosis due to interleukin 6, interleukin 17, and transforming growth factor. With the reports of its inhibition effect on the progression of osteoarthritis, along with its reparative effect on cartilage, right? So now, because of that, we can now consider Losartan as a drug of a choice to manage osteoarthritis. This is a new thing, and I'm telling you that the medical or the frontiers of medicine, they will be very excited now because now they have an other answer for managing osteoarthritis, not just giving them anti-inflammatory drugs, the NSAID, which can damage the kidneys, um, and giving them steroid, which is immune suppression and the side effects of all the steroids, including atrophy of the cartilage. So it's not a good thing, right? But also, Losartan, if you give them too much, you can suppress the free radicals, even physiological free radicals, same like cortisone, and you can cause destruction of the cartilage as well. So very important that we need to know the dose of Losartan does not exceed the amount that we are using for hypertension. For the joint, I will go with 5 milligram. We'll start with that per joint. But totally, I will not inject more than in the body more than 20 milligram, just to avoid the hypotensive effect of Losartan. Unless we load them inside the platelet nanoparticle and you have that slow release, possibly will not cause that dramatic change in the blood pressure. But if that's the case, there is other solution. You can add methylene blue, and methylene blue will negate the hypotensive effect of Losartan. That's a good news. So when you inject those joints, you want to be peace of mind that they will not, the patient will not have any hypotensive effect. Just add into your cocktail methylene blue. So Losartan has recently attracted attention as therapeutic drug for cartilage repair, right? That's a good thing, especially if we start earlier during the damage of the cartilage. We can stall the whole process of cartilage damage. However, to the best of our knowledge, few reviews summarize the effects of Losartan and angiotensin II receptor antagonist on cartilage repair. And this study is the first systemic review on the topic, and our aim is to report the latest. That's what we do in CDP-MCS. Evidence on the effect of Losartan or angiotensin II receptor antagonist on cartilage repair with focus on clinical relevance, we hypothesize that angiotensin II antagonists will have beneficial effect on cartilage repair via reduction of fibrocartilage. We know that if we inhibit the signaling of angiotensin II type 1 receptor by using Losartan, we can definitely inhibit the expression of transforming growth factor beta, interleukin 6, and interleukin 17. And that would help to prevent the differentiation of the hyaline cartilage or the cartilage of the joints, of the hyaline cartilages of the joints into fibrocartilage, because we don't want fibrocartilage, we want hyaline cartilage. It's the same concept when we have liver. You don't want the fibrosis, you want the parenchyma of the liver cells, right? Because if you have something that stimulates the fibrosis, it will squeeze and replace the hepatocytes. And that's why Losartan can be a candidate for treating liver cirrhosis as well. So there is evidence of beneficial effect of angiotensin II receptor antagonists on osteoarthritis and cartilage defect models in both in vitro and vivo studies across animal species. However, this is the problem, same like steroid, high dose may cause paradoxical cartilage destruction. Why? Because you don't want to have complete suppression of transforming growth factor beta or complete suppression of NFK beta, because NFK beta, we know, it gives you that physiological free radicals that will help to trigger the stem cell proliferation differentiation. So you have to have some of physiological inflammation, physiological free radicals going, and some of those physiological level of interleukin 16 and 17 and transforming growth factor to kickstart the stimulation of the stem cells and to kickstart the stimulation of the proliferation. But too much, it's not good because you suppress the whole thing. You suppress the free radicals to the point you don't even have physiological free radicals that will kickstart the cell proliferation. And the other problem we have is the hypertension, right? Hypertension effect. And we said that we can negate that using methylene blue, or we can negate that by not necessarily using high dose, especially oral ones, right? I can go ahead and do the injectable ones, load them inside PMP, and we know the platelets nanoparticle will carry those losartan into the pathology. Why? Because the pathology is more leaky than the healthy tissue. And the nanoparticle is a size that will filter to the pathology, but not into the healthy tissue. So it's what we call target therapy. So to adequately monitor the adverse effect and test the effectiveness of angiotensin II receptor antagonist in targeting osteoarthritis and cartilage defect in human, we need to have double-blinded, randomized control clinical trials will be conducted. But who's going to do that? I mean, the big pharma will not be interested to spend all the money to do this blind study, multi-centric thing because there is no money and no incentive there. So we as doctor, because losartan is FDA approved, we can just go ahead and move forward based on what we learned from those studies that we can go ahead and inject them into the joint as repurposing drug. And the compounding pharmacy can create for you injectable losartan. There is only one compounding pharmacy who's doing it. And I was able to reach out to them and we are going to work together because there is many applications for losartan injectable. We can use it for treating cancer very effectively. One of the thing and the drawback or the problem that I have when I was treating my dad with the hypopharyngeal carcinoma is that those cancer, the squamous cell carcinoma, they're like a nest with a lot of fibrotic tissues, and it's preventing, those chemotherapy or photodynamic therapy that we did, and even the white blood cells of the immune system to reach into those cancer cells because of the fibrosis. And at that time, I was unaware about, the role of fibrosis in hindering and changing the tumor microenvironment in favor of the cancer, right? It's protecting them, and it's like a nest or a rib cage, and that's protecting the cancer cells. The same like when you dive into the water to see the shark, you will be inside the metal cage so that the shark will not reach out to you. Same thing, those cancers or cells are being hid inside those cage, preventing those shark of or white blood cells from destroying them. And adding losartan in your cocktail of your chemotherapy or photodynamic therapy or wherever how you're treating cancer with or immune therapy, we're using all those things really. And metabolic therapy, add losartan in your cocktail will definitely help to break those fibrosis. We're going to see a very nice illustration in the coming slide for this effect. In this case, in this case report, we describe at 60 years old, this is what happened. If you end up giving too much of losartan and the patient has hypertension, what you will do, right? We have to have answers for all those things, right? And we do have an answer, which is methylene blue. And remember I said to you, methylene blue has to be in each cabinet of ER from now on. And why we need to have methylene blue in ER? Because most of the death that happened due to sepsis, especially during COVID-19, they die from sepsis. They have no answer for them. They just, he's done. The blood pressure is dropping, and they did everything that we know as a mainstream medicine. They give them the nootropics, they give them the cortisone, they give them the antibiotics, they give them the fluid, they give them the albumin, they give them everything, but still the patient is deteriorating and dying from hypertension, from septic shock, right? So what will be the treatment? How I can save those people? We can't save those people if they know there is already methylene blue has been integrated in the logarithm of treating shock or vasoplegic shock or anything that's causing refractory hypertension. It's being added in if not all the medical schools, but some, and few of them, maybe less than 1%. But the mainstream medicine does not recognize methylene blue in managing refractory hypertension up to now. And we can definitely save a lot of lives from anaphylactic shock, from septic shock, from tumor necrosis or lysis syndrome. All of those can lead to this refractory hypertension that's unresponsive to the traditional protocols that we're using of giving the patients steroids or giving the patients antibiotics or giving them inotropics or vasoconstrictors. All this are not working. The one that works the best is methylene blue. And so if the patient got intoxicated with losartan, an angiotensin 2 receptor antagonist, the patient perceived, this 60 years old man, this patient presented with a systolic blood pressure of 60 millimeter mercury and metabolic acidosis, hyperglycemia, and his condition worsened with the first hour of arrival, despite infusion of the 4 liters of saline and epinephrine, norepinephrine, vasoconstrictors and vasopressin, and inotropic as well, and insulin and antibiotics. All of them, they'll fail. The only thing that saved this patient, we can save many of them, maybe millions of people who died during COVID because of the septic shock, can be saved by intravenous methylene blue, 75 milligram, was infused over the 5 minutes, and within 30 minutes, his systolic pressure increased to 100 millimeter mercury, and this infusion of epinephrine could be reduced for hours, and the infusion of epinephrine could be reduced 4 hours later. So what I'm trying to say is that this is what exactly I did with my dad when they told me, hey, you know, he is on epinephrine, he is on all the inotropics, he would give them fluid, but his blood pressure is not controlled. And if we take out his epinephrine inotropics, he will die, right? And I did recommend, I told him, hey, you know, just add methylene blue in your cocktail, you can definitely wean patients from the norepinephrine. And that's what they did exactly. And yes, my dad, he came from death because clinically he's dead out of, you know, he's on machines. He's on the infusion of epinephrine to keep his blood pressure. And he's on oxygen at that time as well, which is because of the obstruction that happened in his larynx. And what saved him, or in other words, turn him back to life, is by using methylene blue. Okay. So we know that the central pathological feature of osteoarthritis is the progression of progressive loss of articular cartilage, right? So when a patient gets injured, for example, during the sport, whatever game it is, football, soccer, whatever, what would happen to that injury? It will progress, and those patients or those people, they will end up having osteoarthritis early in their stage of life. So instead of having it at the age of 50 or 60, they would have it at the age of 40. And so we know that the cartilage, the reason why, because the cartilage has a limited regenerative capacity and they don't get the blood, right? They are avascular. And I think by using transforming growth factor beta-1 inhibitors such as Losartan, we can improve the cartilage repair because you are blocking the angiotensin 2 and the angiotensin 2 type, angiotensin 2 receptor type 1 signaling and the expression of the transforming growth factor beta, interleukin 6, interleukin 7. So you're decreasing the inflammation and the fibrosis, and you are inhibiting the differentiation of the cartilage into fibrocartilage, right? By using Losartan, it can improve the cartilage repair by promoting the hyaline cartilage in a state of fibrous cartilage, right? Because a transforming growth factor beta, interleukin 6, interleukin 7 will differentiate the cartilage into fibrocartilage, and we know the fibrocartilage cannot stand the mechanical friction of the cartilage of the knee joints, right? You need the hyaline, that slippery surface of the hyaline cartilage. And so by inhibiting the angiotensin 2 receptor type 1 signaling, by inhibiting the expression and the signaling of transforming growth factor beta, interleukin 6, interleukin 17, we are able to prevent the differentiation of cartilage into the fibrous cartilage and keep them differentiating into hyaline cartilage. So, however, they are concerned about the side effect associated with oral administration. You know, if you give oral administration, you will not have enough of Losartan going to the joint that will cause significant anti-fibrotic effect that we are looking for. So Oral Losartan will not be ineffective. So what you need to do, intra-articular. And that's why we have this compounding pharmacy who can make the intra-articular a joint injection, or can make the sterile injectable for the Losartan. You can inject it to the joint directly. 5 milligram will be a good. The other problem we have, okay, let's say you went to this compounding pharmacy, you get the sterile Losartan. Where's the other problem we have now? Is retention. Because if you inject the Losartan into the joint, it will not stay there. It will go. I mean, it will end up into the blood, right? Again, it will diffuse out of the joint. So it will escape the joint. So I think that's the reason. I think I talked to Dr. Cruz. I told him, hey, you need to start doing the PMP, because now you can retain the Losartan into the joint by loading it inside the platelets nanoparticles, by loading them inside the stem cell derived nanoparticles, which I can help you. I can go to your clinics and I can train you how to sonicate. All the process has to be completely sterile. The sterile compound that you're receiving will not touch the air. So the process that I'm going to teach you how to make a whole process sterile. Okay, no pipetting, nothing. You have to keep it completely sterile. The whatever injectable that you gave you, it has to be completely throughout the process of sonication and extrusion and nanofiltration. It has to be completely sterile, right? And that's what I can help you extracting platelets, sonicate it, extrusion, nanofiltrate, and then you have kind of a system in your clinic where you can get those injectables into the pathology and retain into the pathology, what we call target therapy or nanomedicine. So,
hey, Dr. Halasa, that does, and it's important to point out that doesn't work with PRP, right?
Yeah, PRP, definitely. PRP, platelets nanoparticle extracted from the platelets.
Yeah, but what I'm saying is the advantage of using the platelet lysate is that it's better targeted therapy than doing the same process with PRP.
Yes, of course. The reason why, well,
right.
because
it's important to learn the platelet lysate. You know what I'm saying? Yeah.
Right. Even PMP, which is platelets nanoparticle, which is the debris and the vesicles that's coming up from destruction of the platelets, we know is more effective than PRP. And the reason, I think we explain why. When you inject the PRP in the joint, who's going to take those PRP? Because they're a little bit big in size. They're going to be taken by white blood cells. So you can have some immune modulation because of that. But in order to get a trophic effect to the synovial cells, if that's what you're looking for, you need to break them down into their growth factors or into their vesicles, into their nanocytes. So by endocytosis, those synovial cells can eat them. Same thing when you have 6 years old baby and 6 month age baby, you want to give apple for the 6 months. If you give them the apple, they cannot eat it because they don't have teeth, right? But the 6 years old, he can eat it, right? So think about this. Macrophages are the 6 years old and the synovial cells are 6 months. So the only thing to feed the 6 month is to smash the apple. And that's what we're doing in platelets. We are breaking them down by sonication and filtration extrusion. And during the sonication, you are loading the drug inside those platelets and wrapping them and clocking them. So that's what you're looking for. So you cannot really just put the drug into the platelet expecting it will get into the platelets as effective as if you sonicate it and you clock them by the process of the sonication. So there is many advantage of using PMP loaded drugs. And I think I can definitely help you to do that. And it's not just for pathology of the joint, but also for any pathology in your body. If you want to get this drug of Losartan and all those peptides that has anti-inflammatory, like the KVP or those melanocyte stimulating hormones derived peptides or erythropoietin peptides, all those peptides are extract from the hormones. Do you know that? Those peptides that's modulating the immune system or stimulating the growth is or stimulating regenerations. They are hormones and they are pieces of the hormones. So now we're not taking the whole hormone, but pieces of it, which is the effective pieces of those hormones, and they become peptides. So the KVP it's melanocytes.
Dr. Halasa?
Yes.
This injectable peptide nanofiber, what are they made of? The fibers come.
So that's what now here's the thing, okay? So those are Those are peptides. They're not FDA approved, okay? And I don't really recommend you to go into things that's not FDA approved. Whether it's polymers or liposomes or this form of peptides, but I just presented here to show you that it's better to block or putting it in nanoparticle. But it's as a clinician, we want to put it in a practical way. We cannot do it with this amphiphile nanofiber because it's a lab thing, and then you don't want to use anything that's not FDA approved in your clinic. So I don't know the source of this. I'm just using it just explaining it, presenting it here, that the Losartan has to be clocked into nanoparticles to keep it inside the joint. And I'm telling you the best way of doing that is using plateless nanoparticle. Again, plateless nanoparticle is delivering all kinds of drugs, peptides, anti-inflammatory drugs, antibiotics. If you want to have, you have problem with antibiotic, you have antibiotic resistance drugs. If you load them with PMP, you'll break the resistance. If you have cancer, the same thing. You want to get the drug into the cancer, chemotherapy, phototherapy, drugs, put them in plateless nanoparticle. You get them there. If you have blood vessels injuries, right, or scarring, or myocardial infarction, or cardiomyopathy, or liver cirrhosis, or anything, what's the best way to get the blood, the drug into the pathology, into the injury, into the inflammatory side, attaching cancer cells, attaching senescent cells, inflammasomes, is by loading them inside PMP. And I think we can teach you how to do that. Now, what about stem cells? If I take fat stem cells, and we can teach you how to take fat stem, but in the beginning, we teach you how to do transfer of fat. And the process of transfer of fat, we can also help you to extract the stem cells, the same setting from fat stem cells. And then me and Dr. James, we can come to your clinic and teach you how to do cosmetic procedures, which will help you a lot in the clinic doing cosmetic procedures. You know, those face filling with fat, and breast augmentation, and even remove. And you don't require a lot of fat to be extracted. You know, it's not a big procedure. It just maybe 4 or 5 syringes will be enough, and that will take 50 minutes. And then you can transferring fats. And also, if you want to go ahead and say, I want to extract the stem cells and putting it in the joints, and I will go farther and take those stem cells from the fat, sonicate it, nanofiltrate, mix it with drugs, and then put them into the joints. I think it's the best way of doing it. And this is the way that they're doing it here. Same thing, sonication. They're using extrusion, right, which is passing the drug and throw a filter, passing back and forth, and then you inject it into the body, and those nanoparticles derived from the fat, from the stem cells or from the PRP, will definitely get your drug into the pathology. Same thing here. This is how you clock it from the stem cells or from the platelets, and you can get them into the pathology. All those drugs, whatever you want. You can have a cocktail of Losartan, NAC, methylene blue, hydrocortisone, all the peptides you want to do, KVP, whatever, erythropoietin peptides, name it. Whatever you want to do, you can just go ahead and put them all in your plateless nanoparticle and inject them into either IV or into the pathology itself, into the joint. If you want to inject it into the liver, you can, into the cancer, the tumor. Even if you give it IV, still it will take it into the pathology versus giving it naked, right? If you inject it to naked, maybe 0.001% will get to the pathology. If you do it with nano, maybe 0.1 to 1% gets into the pathology. So it's a way almost 100 times more targeting than giving it by naked therapy. And you minimize the side effects, right? When you have the drug, interest of the drug goes into the pathology, does not go everywhere too much, then you minimize the side effect and toxicity of that specific drugs. Again, we still have another 10 slides, so don't go. But in the middle of this lecture, I definitely want to promote chronic disease prevention and management. And I do recommend everybody here, so we've been almost 1 year, 2 years here talking and all that stuff, but we need to turn your clinics into chronic disease prevention and management, because it's being blessed by the American Medical Association. They are entertaining chronic disease prevention management. They see there's a gap in the medical specialties where they are not able to master the chronic diseases because it's multisystemic diseases. And if it's multisystemic diseases, if this patient goes to a neurologist, they say, okay, I'll take care of the neurological part, but what about other parts? In other part, if you have hypertension, diabetes, if you have toxicity, if you have fungus infection, all of this can aggravate that neurological disease that the patient is suffering from. And the neurologist say, I don't have a training to manage fungus or toxins or diabetic hypertension or metabolic syndrome or rheumatoid arthritis. You need to go ahead to all the specialists. But they end up going to one specialist to another, getting a bag of drugs, all those medications conflicting each other, and the patient is not being taken care of. And that's the reason why we need to develop this new medical specialty where all these specialists, they can go ahead and have the training and become neurologist plus CDPM, gastrologist plus CDPM, chronic disease prevention management specialist. So they can manage the patient as a whole. Yes, maybe the main problem is CNS. Okay, so it goes to neurologist, but also you can take care of all the risk factors and all the contribution factors and all other conditions that aggravate the main condition, let's say dementia or Parkinson or whatever. So that's the reason I'm asking you, even as a specialist, to upgrade your clinic as CDP-MCS. You can say I'm a neurologist plus CDP-MCS. Using integrative, regenerative, holistic, all this terminology, I'm not against them, but they're being red flagged and they're being abused. I think we need to use a title that's being blessed by the American Medical Association, where they're trying to insert the education of CDPM into the medical university, into the residency program, fellowship program. So let's do it. Let's take this title, and I will help you, because it's not just doing regenerative integrative. It's doing really all whatever it takes to help the patient, whether it's integrative approach, regenerative approach, mainstream medicine approach. And the mechanism or the way we approach patients to manage chronic disease is by restoring and modulating the redox, metabolic, immune, and regenerative status of the patient. This is the 4 pillars of chronic disease prevention and management. So again, yes, if you have any companies, any products, any innovative like compounding pharmacy or other medical device, laser, electromagnetic, they want to sell their products to CDP-MCS doctors, we can help to entertain you here in this room and this conferences. We're looking for investors to set up CDP-MCS clinics. We're looking for doctors. Anybody here wants to speak and present your cases after learning all of this? Can you get the effect of whatever you learn and whatever you're adding and whatever you're adding from your skills? And we don't want to learn from you as well. So speaking at CDP-MCS education platform, joining the CDP-MCS fellowship program, and we need some people to go ahead and start either joining the CDP fellowship program and getting the PMP training and all the fast transfer that we can do for you. And that's all on the website, cdpmcs.com. If you want to promote, you're a salesperson, you want to promote CDP-MCS, we will appreciate you financially, and you will be part of this group and part of this mission of advancing medicine. Again, in my website, there's a click where you want to donate to CDP-MCS. There's everything, all the options that we want all of you to be part of it, whether you're a salesperson, whether you are a medical doctor, whether you are innovative, whether you're a speaker, please come. There's all the options for you to participate and contribute to advanced medicine with us. Let's go to further seeing the use of Losartan, not just for limited to cartilage or limited to osteoarthritic, but also we can use it to manage all kinds of fibrotic diseases, okay? And let's give an example. We can use it for treating eye fibrosis, which is scarring of the cornea, right? And in the first one published in experimental eye research in early 2022, researchers tested the use of Losartan in rabbit after DC metorrhexis. It's a surgical removal of an 8mm patch of disseminates membrane and the corneal endothelium. So they apply Losartan patch on this cornea of the rabbit after they remove a piece of it. And what happened is that it did help to prevent the scarring, right? And so the rabbits received topical Losartan 0.4 milligram per mil 6 times per day. And they received oral as well, but oral in a very high dose that you cannot use it really for humans. It's higher than what's pharmaceutical dose for hypertension for humans per day. And after 1 month, the corneas treated with a topical drug were clear, right? Clear from scarring, and began to disappear, the scar in the peripheral, and the clearing effect were moving toward the center of the cornea. So that's a good news, right? That we can turn now the blind from scarring of the cornea back into seeing. I know one of the miracle of Prophet Jesus was treating the blinds, right? So if you put topical Losartan into the cornea, it will clear the sclera of the cornea and make those patients to see again. That's a big thing. Maybe it's one of the biggest discovery in ophthalmology up to now, right? Is to have something that cleared the scar tissue from the cornea. Do we have other drugs that does the same anti-fibrotic? Yes, but it's not as effective as Losartan. We do have antibody blockades of interferon, transforming growth factor betas, maybe cytokine blockades for interleukin-6, but those antibodies cannot penetrate deep into the cornea, right? So if you have here epithelial that's covering the scar, those antibodies cannot get into the scar tissue. But Losartan, because of small molecules, you can get them into the scar tissue, the thickness of the cornea, and go there and remodel the whole cells of the cornea back into a clear tissue. So, and what causes the scarring is the myofibroblast, right? Activation of this myofibroblast by transforming growth factor and laying down too much of collagen, dense ones, that would definitely lead to the scarring of the cornea. And we know that Losartan does inhibit the stimulation of myofibroblast by interfering with the interleukin-6, interleukin-7, and transforming growth factor beta. So the effects of topical Losartan on scarring were expected to be even greater after several months of treatment. So this is just 1 month and we see the clearing, right, in the peripheral of the cornea and going to the central. And the dose was 0.44 milligram per ml. Now, do we have a compounding pharmacy creating a topical Losartan? Yes. And we have that on our, and I think it's the only one. I was proposing that to one of the compounding farms. I don't want to mention the name of it. And he did it, but in order to move it, you really need to have the education platform. And that's what we're doing here. We need to have education platform for all this innovative things, especially for compounding pharmacy. They are the one who is spearheading the pharmacy industry by using this repurposing drugs into different applications. That's compounding pharmacy business. It's basically repurposing whatever generic drugs and what's ever been approved into different applications, different doses, different forms. And I think that's the reason, you know, those compounding pharmacies, they have to be leading with us and joining us to frontier the medicine together, because it requires a lot of education to get the doctors on the board, and that's what we're doing here. So the first successful trial of topical Losartan after removal of an 8mm circle of the deciment membrane and endothelium, which is called the decimentohexis, DMR. See here, the left panel, see the left panel here? Okay. And did you see it here where it's being removed? Okay, so the left panel, unwanted cornea treated topical 6 times per day with 0.4 milligram Losartan for 1 month, showed no sign of toxicity. So this is normal. We did not do anything here. And we want to check the toxicity of Losartan with a normal cornea. So that's a good thing, right? Now we know that Losartan is safe. If I put Losartan in my eye and I don't have anything, nothing will happen to my eye. So there's no toxicity to the normal eye. That's very important when you are trying to translate a drug into clinical. First of all, you have to make sure it is safe. okay? And it's not toxic to the normal tissue. And that's what they did here, okay? Here in the middle, they removed a piece of the cornea membrane without putting any Losartan, and see what's happening to the scarring tissues. They end up the cornea all scarred, right? Here, they remove the piece of the cornea membrane, plus they add Losartan, and you can see the protective effect of Losartan against the scarring comparing to this one, right? See here, the clearing here and the central clearing here. So in the middle, the cornea that has this hexes and then received topical vehicle 6 times a day for 1 month show severe corneal scarring, which is the fibrosis extending into the periphery of the cornea, and also corneal neovascularization. So this one, they just remove the piece, and also they add vehicle, not Losartan, those peptides that we talked about that helps to wrap them. So not the Losartan, so just the vehicle. And then here on the right side, they add Losartan, and then they remove the membrane of the cornea, plus they give Losartan. So cornea that had this metrohexes and then received the topical 0.4 milligram per ml of Losartan, not vehicles, 6 times per day, only for 1 month, show markedly clearing peripheral of the cornea. See, comparing this one, comparing to this one, along with significant decrease in the corneal neurovascularization, right? See this neurovascularization, this blood vessels here, there's less here comparing to here, okay? An area of significant central stroma clearing, lacuna, which you see it here, okay? And this is, so if this is happening to the eye, and I think for pain management doctors here, like Dr. Mikhail and Dr. Cruz and all those pain management doctors here, this is a good news for them. Why? Well, we have problem with epidural fibrosis and spinal cord stenosis, which is caused by fibrosis. And we have no answer for that. Steroid does not cause that effect that we're looking for. It may cause some reversal of the fibrosis, but once you stop taking the steroids, it goes back, those fibrosis, right? While Losartan gives you that long-lasting effect of anti-fibrosis. And that's mean there is a big application here for using it to manage spinal cord stenosis and epidural fibrosis, which is one of the dilemma, hard to treat, and most of the failure of the pain management, they will ask them, those doctors in pain management, because I was one of them and I was doing pain management, is the fibrosis, right? That's one of the problems, one of the biggest problems, that the challenge in pain management is the epidural fibrosis. They don't know how to deal with it. And it's causing the irritation and squeezing and pressure and pressing the nerve and causing all this radiculopathy and pain and cauda equina and all this stuff. So, is anybody inject epidural with Losartan? Up to now, 0 worldwide. Okay, they inject the joints, but not the epidural. So we need the frontier of doctors who will be doing it. But who's going to do it? Going to see. Okay, so the oral dose was far higher than what human would use for hypertension. So I don't recommend using oral dose thinking it will help or clearing the sclera. You really need to have the topical steroid one, and you can get this from the compounding pharmacy who is actually working with us. Yet it has no effect on the cornea, right? Even with high dose. And then you end up with side effects of high dose of hypertension. So using oral and topical dose together also did not increase the effect of the topical dose. So even if you use both, it does not cause much change. Topical is the one we need. So we think it's because Losartan's oral route does not penetrate the cornea like the topical route, or because it's too high dose and we're not getting enough of the amount of Losartan to get into the cornea. So this first study showed that even with epithelium at the front of the cornea intact, let's say if the epithelium of the front of the cornea that's being scarred is intact, right? Losartan can penetrate those epithelium and getting into the deeper tissue of the cornea. If I use antibody blockade of Ig transforming growth factor beta or interleukin 6 or interleukin 17, those antibodies cannot get into the deeper. They cannot pass through the epithelium that lines or that cover the cornea. So topical Losartan can affect the entire cornea all the way right to the endothelium, to the back of the cornea, and this is a critical finding. So while previous studies have suggested the scar healing effect of antibodies to transforming growth factor beta, those transforming growth factor beta blockade, those and other substances that's in the market will not penetrate the closed healed epithelium. That's the problem. Okay, so if I have those big pharma, they have the antibody blockades and cost thousands of dollars. Yeah, but they are not going to be as effective as Losartan, which is a generic drug that cost a few dollars. As a result, their overall effect on scarring fibrosis is limited. So it's likely will take weeks, months of continuation of anti-GF beta antibodies, anti-GF transforming growth factor beta effects to see any meaningful reduction of fibrosis in humans. So it's not enough to just give them 1 month course of this eye drops, right? We need to go ahead and give them more and more and more, maybe up to 6 months, and then see, and if it's completely clear, that's good, right? So this is very good. I know Dr. Patel's husband is ophthalmologist, and lucky is that the compounding pharmacy that we know, it's in New Jersey, I think, so it's not far away from you. For your husband can benefit from this eye drops. It will be one of the leaders. He's not the only one. Okay, very important that there are already ophthalmologist doctors in the United States. Few of them are starting using topical Losartan. So he will not be the first, but he will be among the pioneers. Now, my question here, can we find a pain management doctor to at least start doing it inside the joints? The joints articles, intra-articular, it's not a big deal. They're already being done there and safe there. Epidural, you will be the first in the entire world to, because I didn't see any article publication showing epidural Losartan. But if it's safe on the cornea, epidural, you know, which is the space between the bone of the spine and the meninges, right? That's epidural, between the dura and the bone. So it's kind of a joint. Something you may consider. Maybe we will be pushing doctors to do it. At least they start with the joints, like knee joints and all that, and then if they feel comfortable, they can, especially for failed cases that fail everything, and you know, especially the spinal cord stenosis, and they can go ahead and give just 5 milligram caudaquina along with cortisone. I mean, I'm not saying that we don't want to use cortisone here. We use cortisone, but along Losartan. And we find out that cortisone and Losartan will be more effective. So publish it in the second study, published in the summer in Translational Vision Science Technology. The team evaluated the use of topical Losartan and cortisone to heal rabbits' cornea from alkali burn injuries. So it's not just different kind of injuries of cornea will work to the epithelium and stroma endothelium. And we find out it's working for cornea that's been burned. We know a lot of patients who have victim of burns, accidents, and injuries, where they cannot see because of the scarring of the cornea. They now can see if they start using Losartan topical. Compared to corneal treated with Losartan, 0.8 milligram per ml 6 times per day, or cortisone alone, those treated with both medication, cortisone and Losartan, show significant decrease in opacity and fewer myofibrils. They got stunned in the stroma after 1 month of treatment. So I do recommend combining steroids with Losartan to get the maximum effect. The third study, publication was pending, supported by research to prevent blindness funding. Evaluated the use of topical Losartan 0.8 milligrams, so more than the first time. That's 0.4, this is 0.8 milligram, 6 times per day to treat late haze after photoreactive keratectomy. Again, the team found decreased corneal opacity and fewer myofibroblasts in the stroma after 1 month. So this is a good news, right? So any kind of injury of the cornea, regardless of what it is, right? And it's causing scarring, there's microfibroblasts there. Losartan will work and will help those patients. Any
Okay.
kind of injury.
I have a question. How did they arrive at 6 times per day?
How they do it?
How did they arrive to be used 6 times per day?
Yeah, you can, the compounding pharmacy will give the eye drop to prescribe it, and the compounding pharmacy will just dispense it for them.
Yeah.
They can use
I
that
get what
home.
you're saying, Dr. Patel. But what Dr. Patel is saying is that how did they decide on that frequency of dosage and if that was necessary? So like if we were trying to translate this into other topical applications, like let's say we wanted to do a topical tumor application or something, what Dr. Patel is pointing out is, how often per day is a reasonable dosage schedule to achieve these results? Because 6 times a day would be a lot, right? If a person had to put eye drops in their eyes 6 times a day, that would be a small price to pay for curing yourself, obviously. But is that your question, Dr. Patel? How do they
Right,
determine?
but I mean, you have to explain to the patients that if you are going to use something
Yeah.
6 times a day, a patient is going to, why 6 times a day?
Well,
Well,
Yeah, they're not
you
even,
will heal
they won't
better,
even listen.
yeah, but
Right.
anyhow, we saw that in 1 month it got better, but it's not even 1/16 or maybe 1/32 part of it. So it may take 6 months, it may take longer, and to expect that to do 6 times, we have to have some idea that they have done that in the laboratory and they saw that
yeah, this has been
it
published.
had the improvement, but we don't have anything to back up this.
No. This dose and times, it's being published. This is not me telling you to do this. This has
Right.
already been published and it's being worked through with humans and with mice. And there is already compounding, already ophthalmologists here in the United States that are using it. Maybe they modify the protocols where they do it more longer time instead of 1 month, 6 months, and 1
Okay, do
year.
you know that who did the research and where was it published from?
I will
From
share with you
university?
all. I will share with you all of that. But I think that we're already mentioning some names here. The blindness funding institute, and there's many others. The translation of vision science technology also. There are already publications, and this is what they're already being used for animals and for humans. But the compounding pharmacy, who we're going to work with, he already have ophthalmologists who are already using it with great results. And we are asking those compounding pharmacies to invite their doctors to attend our meetings so they can give us their perspective in what they're doing it currently. So that helped a lot to encourage other doctors to do the same. You got my point?
Yeah.
Right.
I have the study here. I'll put it in the chat, Dr. Patel. But your point's well taken, that a patient has to be able to do it. Now, I'm wondering if the other thing that we sometimes find in these studies is that they don't really have an optimized vehicle. A lot of times when you look at it from a pharmacy point of view, the initial research has done something, real simple like saline, and they haven't done anything to try to, amplify the absorption. But, another thing to think of is, and I don't know about this, but we talked about using platelet lysate for eye drops. Would that possibly be interesting here?
Yes, then the patients will be done and they will get the injectable from the compounding pharmacy, and then they load it with platelets, nanoparticles, and then they put it in the form of eye drops. So there's 2 options. You can do this, or you can just get it from the compounding pharmacy who has already been dispensing it to the ophthalmologist and using it as it is. That's something you need as a doctor to, come up with that.
The platelet lysate effect will not be, platelet lysate you can't use for too many days.
Right.
Because of the growth factor.
And you get the benefit of the platelet lysates growth factors plus adding.
No, I understand that. But what I'm saying is the lifespan of the platelet lysate solution as an eye drop, I thought that you can use maybe 4 or 6 days. You can't use longer than that.
Yes, because of the contamination, all that stuff. You have a valid.
So that's a limiting factor.
Right. There is limitation factor. That's the reason. Just go ahead, prescribe it from the compounding pharmacy for this application. But for cancer, you don't need that. You can just go ahead and do Losartan, inject into the tumor, and just do it every other weeks and all that. It's better with and then the injectable into the site of the tumor. Even if you do it IV, it's still with Losartan is better than oral, because the amount of Losartan, it's going to be there more than naked drugs, because of the targeting effect of the platelet nanoparticle. So all three of these.
I put one of the studies in the chat for you, Dr. Halasa. The one is from the NIH
Right.
on topical Losartan inhibits corneal scarring, fibrosis, and collagen type 4 deposition. So that's in the chat.
So all three of these recent studies show that the topical Losartan decrease the production of myofibroblasts. And the main types of the cells responsible for corneal opacity is myofibroblasts after injury or infection. While all these studies involve applying Losartan preventive at the same time as the model injury, I believe myself, and maybe other doctors will agree with me, Losartan can have similar success on any scarring caused by fibroblasts, no matter how long standing and what organs are being affected. So we think that because we think that the fibrosis and the fibroblast, it's dynamic tissue. And if you stop the transforming growth factor beta signaling and interleukin 6 and interleukin 17, this will stun those myofibroblasts and eventually they will die. And this will kind of rejuvenate the tissue and recycle those fibroses, and eventually you will get those eliminated, those fibroblasts.
How long standing? What? No, does it?
Yeah. Hey, Dr. Halasa.
Yes.
Yeah. So, when I first was listening at the beginning of the lecture, I mean, I was, taking it in, I knew something was going to be much bigger in my mind, as there usually is, especially when you're coming up with these new innovations. But it seems very big now because, I started thinking about all the different scar tissue issues. I mean, bulging discs, herniated discs, chronic back pain, injury, even all the surgical procedures that have chronic issues with scar, probably having to do with scar tissue. And what I'm hearing is that Losartan is giving more like a dramatic result. I mean, I've thought about scar tissue as kind of like, if we could get rid of scar tissue, that's super huge. I mean, that because nothing we've ever done could really get rid of it. But then and so I would consider things like thymosin beta. There's something that has not been released out there called Clotho, which is actually a peptide version of Clotho, which is produced by the kidney, that they have shown studies with reducing or reversing scar tissue. But really, when I think of Losartan, I think of something that really just pushes a button. Sometimes we need, the medication that just pushes that button. And it sounds like the platelet-derived nanoparticles, that's what's giving it more of a long-lasting result. Is that the idea?
Yeah, so it's more lasting in the body. So it will be like constant release, right, of Losartan from those platelet nanoparticles. It delivered into the pathology instead of going everywhere. So if you do IV Losartan, it goes everywhere. But if you load them, you get them into pathology, and also it stays into the body longer because they're being protected and they're being capsulated. Even for the peptides that you are proposing, whether it's erythropoietin derived peptide or melanocyte stimulating hormone derived peptides, all those peptides, thymosin beta, whatever you're talking about, it's injectable forms, definitely loading them and wrap them and clocking them into the membrane will protect them from degradation. It stays longer in the body, right? So there will be change in their pharmacokinetics. And it takes them to the pathology. It attached to the inflammasomes, to the senescent cells, to the cancer cells, to the infection, to the bacteria, to the virus. it has this tropism effect, natural tropism effect from the membrane receptors of the platelets or the stem cells. You can do it both, but the more cheaper, more affordable is the platelets, right? And more peace of mind and more accessible.
Yeah, and I was going to say the way I typically treat a lot of the musculoskeletals or things that I can inject is doing an IV and doing a local injection. So it's like hitting it from every angle, and that's where I've gotten the best results. But yeah, I mean, there's so many situations, you know, even I'm thinking, you know, what about, I'd like to see if I could find something on like adhesions from
Yeah,
previous abdominal surgeries. You know, I mean, they're just, you know, the more I think about it, the more I can think of scar tissue related issues.
FSHD.
Yeah, I mean, we're treating, you know, FSHD patients, or, you know, a couple patients, actually a family of patients with FSHD, and the limiting problem is the scar tissue that covers the atrophied muscle in certain parts of the body, like the hands. It's a hard thing to, you know, we've got strategies to, you know, buffer the redox to stimulate muscle growth, but the muscle growth isn't happening because it cannot get past the scar tissue. So the more I think about it, the more situations I can think of where we need something that has that predictive power to, you know, push those buttons, release the, you know, reduce the TG, I'm sorry, sometimes I get it wrong, TGF beta production. And again, it's reducing it simply because it's blocking that angiotensin 2 type 1 receptor, correct? That's the
yes, because that is the signaling to increase expression and the signaling of the transforming growth factor beta, in addition to interleukin 6 and interleukin 17. You're right. Yeah. And the thing is that even if you have scar tissue for a long period of time, it still Losartan will work, because, as I said, those scar tissue, they are in its dynamic status. They are in renewal, right? And once they're renewal, then and you have the Losartan there, it will definitely block the stretched expression of transforming growth factor beta, preventing the fibrosis from taking place. And that's the reason the cells are constantly dying and dividing, relying on continued supply of transforming growth factor beta. And if you can block that by blocking the angiotensin 2 type 1 receptor by the Losartan, if we interfere with the transforming growth factor beta signaling, even if the corneal injury occurred months or years ago, fibroblasts will likely undergo apoptosis. So that's a good thing, because what keeps them and what keeps the fibrosis going is the angiotensin 2 type 1 receptor signaling. And if you block that, then we can stun those fibroblasts and maybe induce their apoptosis and replace it with the normal tissue. So in their place, normal corneal cells, keratinocytes, corneal fibroblasts, that's normal, will move into the damaged tissue and restore the corneal transparency. I think this can happen to the epidural stenosis. It can happen to intestinal adhesions. It can happen to the cardiomyopathy. Also, there's fibrosis there and will help to shrink or decrease the thickness of the heart wall. This can happen for pancreatic fibrosis, lung fibrosis, name it. All these are fibrotic disease here. Cirrhosis, retroperitoneal adhesions, intestinal fibrosis, adhesions, joint arthrosis, you know, skin. We have a lot of skin disorder. And I remember one of the case that they had excessive amount of keloids, and any injury, even scratch, like they end up with big keloids. So if we can develop topical cream that contains Losartan, that may help. So I think
Dr. Halasa, just one point here in gut. If you see that it says enteropathies and inflammatory, but there are some patients, post-COVID patients, and including the mold-related exposures and diseases deriving from that they have a severe degree of constipation.
right.
And they say, oh, well, it is from the vagal nerve syndrome. I'm just wondering that, because TGF beta is part of that disease with the IL-6 and all inflammation.
Right.
still not getting better for a year, 2 years, 3 years. So do you think that there is a factor like intestinal fibrosis? Not
I think
intestinal fibrosis, the fibrous tissue around the network.
I think it is. I think there is fibrosis, and that's happening with any chronic Th17 inflammation, whether it's post-COVID-19, whether any sort of inflammation there's hyper-reactive Th17, because that is leading to this cytokines, transforming growth factor interleukin-6 and interleukin-7 to be overactive and stimulate the fibrosis. And giving Losartan, and especially if we can load it inside the platelet nanoparticles and give them IV drop, just maybe 5 milligram of it, maybe this will take it to the pathology. You don't want to go more than that because you have the blood pressure side effects of it, unless you say, I'm going to add methylene blue in the cocktail to just negate the drop in the blood pressure. But I think that will be kind of an answer for
But
many
if
fibrosis.
they have in the gut, and if they have not, I think
Yeah,
that
you will say
they're blaming
Losartan.
the vagus nerve, but vagus
Right.
nerve does not have a problem anywhere else. So it is say, oh, it is the gut-brain axis. Well, it may be. But
Right.
you know, when 2 or 3 years later, then nobody, whatever they have tried does not work, and patient is 100% on enemas, I have a feeling that what is the problem for the dysmotility? I mean,
Well,
you know,
there's many things. It could be, as I said, it could be fibrosis, could be neuropathy, right?
Right.
The vagus autonomic nervous system neuropathy, all of this. So you really
when
need.
we talk about neuropathy, there may be, you know, it's a nerve-to-nerve communication. You know, there are in the extracellular matrix.
Right.
So even if the nerves are normal, but in the soil where they are sitting, and if it is not normal, their communication is not going to be there.
Right. So that's where you need to maybe consider even oral. This will work for intestine. Maybe 10 milligram, 5 milligram twice. Just you don't want to do it in a dose where it will drop the blood pressure. And especially if the patient has hypertension, that would be great because then you can do both.
Why not to design a capsule where the Losartan and methylene blue is delivered at the same time?
Well, Mike Beamer can do that. He already have the 5
No,
milligram.
I mean, this is something my Beamer can do it, but I
Right.
mean, does that make sense?
Right. That's something we can entertain it. It's all about you doctors here to accept the idea. It's a repurposing drug, and you can start with 5 milligram and then go up to twice, and then you know, and add methylene blue, as I said. I think I don't know if Mike Beamer is here.
Yeah,
Okay.
yeah, I can, and thank you, Dr. Patel, for your comments. We do teach that we don't inject methylene blue, intrathecal or as a bolus into tissue because as a strong redox buffer, it can cause hemolysis locally, by direct action on RBCs. So do we think that's a problem in a joint? And then the question is, I'm not sure we should be talking maybe about milligrams as much as we should percentage of the solution of methylene blue that might be injected, because I think it's more about that. In other words, if you inject it in 5, and I'm not suggesting, I don't know this, but I don't know how many cc's you can typically inject into a joint, but let's say for a good number, let's just say it's 2 cc's. Well, if we put 5 milligrams of drug in 0.1 cc's or 0.2 cc's or 2.0 cc's or 20 cc's, it's all the same 5 milligrams of drug, but the concentration of the drugs varying greatly. And I think that any problems with it will come from the concentration more than the milligrams.
Yeah, that Dr. Beamer, I can add a little bit from my experience. And in making the nanoparticle solutions, say like 10 milligrams, where like 5 milligrams will go into the, into each knee. Okay.
Yeah.
Or even injecting the finger joints. But if I make a cocktail of 10 cc's, I can tell you that I had to reduce the methylene blue, the amount, the percentage of the entire cocktail, even though I buffered with sodium bicarb to buffer the acidity. And I may have started with 0.25 cc's of methylene blue, which I believe it was in a 1 milligram, 1 milligram per 0.25 cc's of methylene blue out of the entire 10 cc's of the cocktail. And
It's
that's
10
methylene
milligrams
blue.
per cc. So yeah, so you would have been
Well,
around. You would have been around 2.5.
No. What I used was one. Is it 10? No, it's I believe it was 1 milligram per cc.
No, it's
Vial
10
of,
milligram.
it's 10 milligrams per cc.
Yeah.
Right.
Okay.
The stuff
Okay,
I
5 ml, 100, yeah.
Okay. So here's my point. I did have patients that had a lot of I would say it was painful into the finger joints. The finger joints were the most had the most common side effect of that. Knees, I think I had I'm trying to think of other things I injected where there was localized discomfort. I may have injected intramuscular dermatomes in the calf for neuropathy, and that was very uncomfortable. And so, I decided that it went away, but I want there to be, it didn't cause any injury, obviously, but there was, discomfort. It was very painful, and it went away, but I didn't, I don't want that. So I entertained the idea of maybe doing 0.1 milliliters, coming down from 0.25 to just a very, very tiny dose of, 0.1. But I just wanted to let you know that, yeah, I mean, even at the very, very low doses, it can be very uncomfortable. And that's a very small percentage of a 10 cc cocktail.
I concur
Gotcha.
with your findings because I have completely eliminated it. And not only that, but even the IV methylene blue, I have a patient, even a small dose, like 1 ml, and they would, particularly my patient population where I am using it, they are sick and they have stage 4 cancer or this and that. But they are shivering, and I just after a while I just have discontinued it, and I would try once. I would try once, and if I find they are able to tolerate, I would continue, because
I get my dad the 20 milligram a day, and he did not have any side effects of that. But again, the shivering thing.
This is IV we are talking about.
Yes,
not
IV.
oral.
Yes, IV. My dad was 25 milligram a day.
Yeah, I agree with that. There are some patients who would be able to tolerate.
I think they have some sort of the G6.
No, G6PD deficiency, we check every patient.
Right.
If you are going to give them vitamin C infusion.
Exactly.
But we have not, they did not have
Right.
G6PD.
The
But
other thing is hemolysis from all those drugs that you're putting can lead to shivering because you're leading to
right, but without that,
hyperkalemia.
they are not shivering.
Right.
Because we have
I
tried. We have tried. Then one time, if they have it, we don't give it. We give the same other medications, whatever were given, and then they don't have the shivering.
Right.
So it is an individual personalized reaction, but I think whoever is going to use the methylene blue, they have to know that they may experience this problem with the patient, so that they are not
And
dumbfounded.
you give them calcium gluconate because that would help too. Because
Well, calcium gluconate, we have used it, but still, it works good for vitamin C reactions, but it does not work as good with the methylene blue reaction.
okay.
Can I add my experience?
Comment on. Oh yeah, go ahead, Dr. Joseph, please.
Yeah, so yeah, I have not had any issues with IV with methylene blue by itself, or loaded into the nanoparticles, except for I did have a patient who had end stage cancer, you know, who was basically, she was hospice, and, you know, that we had only given her the nanoparticles. Really, we were just trying to extend, give her some time. The family wanted, the daughter wanted time for the family to visit, to fly in, you know, give her some hydration, maybe reduce some of the symptoms. And most of them went quite well. We ended up doing something like 6 or 7 infusions. And the last one, where she was getting closer, like she had about a week left, she did have some shivering after. So I can relate with the, you know, what you said with, you know, with the stage 4, very end stage. I did see that happen. It was self-limited, but I saw that reaction, but I have not seen it with any of the other patients.
But see, my end stage, my patients were not end stage. They were stage 4, but they were fairly active, and you know, it was just that we had to. They were carrying on their life, but they wanted to be treated, and I mean, of course, they want to be treated. But
Do they have a sensation of chills or cold, or is it just the
yeah,
is it just the
no
physical?
sensations of cold, and we have 2 heaters going, blanket on.
Yeah. Okay.
And hypothermia laser, and sometimes we have to remove the hypothermia laser.
Yeah, they just can't warm up. Okay, interesting.
How
So
long
we could,
did that last, Dr. Patel? I've given myself 50 milligrams of methylene blue just for anti-aging and strengthening. I don't have cancer.
So that's good.
I had no side effect, but
Yeah.
I'm not a cancer patient, and
That's
I
what I'm
have been
saying, that sicker
reluctant.
you are, you may not be able to tolerate. And that was my take-home message on this.
How long
Yeah.
did the shivering last? Because I mean, is shivering bad, first of all, or is it a healing crisis and we're stimulating something good, is what I'm wondering. And how long were your patients uncomfortable with shivering?
Well, they're more than half an hour, 45 minutes, but you know, it just they are so then get scared that they don't want to get the second treatment. And
You're
and
right. Yeah,
that is psychologically not very beneficial for them.
sure,
So we have
sure.
to say that, you know, this may be the problem. So we are not going to give you next times, and hopefully you have a smooth patch, because until we give them methylene blue, they were fine. So then they understand that, okay, well, one patient with the curcumin, I had the same reaction. So I'm not just saying that methylene blue is a bad molecule, but I think one has to realize that the more, just like the doctor just said that he's taking 50 milligram and he doesn't have any problem, and he's doing it for the maintenance of his health. That's wonderful. But if you are taking care of a very sick person, then you got to be prepared if something like that happens.
Very good. I
And
agree.
I'm wondering what the shivering is, what it's coming from.
it's from lysis of the red blood cells. It leads to hyperkalemia, and that's you can antagonize that with calcium gluconate.
Calcium gluconate, as I said, it did work for other reactions, but not for this patient.
Did not work with this patient.
It did not work with, it worked with vitamin C, but not with methylene.
Not much with the methylene blue.
Okay.
So that may not be the mechanism, is the point. Yeah.
Right.
I know if you have a harsh drugs that killing the cancer, you end up with tumor lysis syndrome.
Yeah, you
And
mentioned
you will end
that.
up with hyperkalemia.
I have gone through that completely,
Right.
tumor lysis syndrome, with a great understanding, so that, you know, if we don't help them, we don't want to hurt them.
Oh, then your body reacts like you can ask them.
So we
So-
created
so is tumor-
Losartan solution for off-label use in patients. I think we have a compounding pharmacy for that, which is allowed in the United States if the medication is FDA approved. That's called repurposing drug. One patient with LASIK surgery had developed severe diffuse lamellar keratitis, resulting in severe scarring fibrosis, that limited vision to 20 to 200. And with 5 months of treatment with Losartan eye drop at 0.8 milligram per mil, 6 times per day, the patient's cornea had returned to total transparency. That's a big thing. And the patient's vision was 20/30. That's a big accomplishment. The second patient with scarring and neovascularization developing years after radial keratotomy saw a dramatic decrease in fibrosis just 15 days after beginning of the use of Losartan eye drops. The patient's continued use of the Losartan and further improvement is being noted. Most recently, the physicians have begun using topical Losartan in patients with recurrent herpes simplex keratitis. So the first 2 patients are far enough that we know they have a dramatic results. And I think there is no other drug treatment has performed like Losartan in this case. Today, conventional treatment of corneal injury involve topical corticosteroids. The problem with corticosteroids, it may have slight effect on scarring, but do not completely reverse it. And long-term use of corticosteroids, as we know, it can cause atrophic effect, right? Can inhibit the stem cells and the regeneration. And the reason because of the suppression of the free radicals, even the physiological ones. So there are side effects of cortisones. Scarring that is reversed during short-term use of cortisone may return when the steroid is stopped. That's the problem with even epidural fibrosis. We're using steroids, that's the treatment. But after you take the steroids out, the patients start having pain again and the fibrosis build up again. So really need to have something that changes the genetics, epigenetics. And Losartan does that by blocking the transforming growth factor effect and expression. However, according to translational vision science technology studies, a combination of Losartan and cortisone may be the most effective treatment for infection, burn, and other corneal scarring condition with high level of inflammation. Topical Losartan likely can prevent or reverse scarring anywhere in an anterior segment of the eye. Anywhere are the myofibroblasts, which cause the most severe persistent types of scarring, right? And I think we can use the same concept for other fibrotic diseases as well. That would include conjunctival fibrosis. We can treat it with that from etiology like trachoma. That's a good news, right? Or scarring of conjunctiva bleeds after glaucoma surgery, and many of patients with glaucoma surgery, they end up with scarring of the conjunctiva, and we can heal them with topical Losartan. Not just that, but we can use Losartan to treat glaucoma itself. We know that glaucoma, there's closed and open. The closed one, where the iris is pressing over the cornea and causing a very narrow entering for recycling of the fluid of the anterior compartments, right? And an obstruction. And then the open one, there's no really pressure or closure of the cornea with the iris, but the trabecula itself, there's fibrosis there. And if we can reverse those, or we can break down those fibrosis of the trabecula at the angle of the eye, we can definitely help patients with open glaucoma using topical Losartan. So there's articles published for topical Losartan using it for glaucoma, yes, and that's a good news. So if the myofibroblast are cause of the scarring and the topical drug can reach the site of the scarring, Losartan is likely to be effective. Again, this is just shows you the fibrotic disease is due to interleukin-17, as I said, transforming growth factor beta, and possibly interleukin-4, which is Th2 inflammation. It can lead to scarring as well. So Th2 inflammation, Th17 inflammation seems like it's leading to the scarring. Treg, the interleukin-10 is negating the transforming growth factor. So if you push the immune system to Treg, don't worry about the scarring, because the interleukin-10 will negate the transforming growth factor beta here. So if I have scarring, I will polarize the immune system to Treg or polarize the immune system into Th1. We can do that with thymosin alpha, or the Treg, we can do it with the KB beta, the KBP which is the melanocyte stimulating hormone peptides, which we're going to talk about maybe next Monday if there's nobody's going to be presenting. Again, when we have injury, we still need TH17 inflammation. We need interleukin 17, interleukin 6, and tumor and transforming growth factor during the acute injury and during the healing process. But we need it at physiological level. But if this injury and this constant pathology, it's causing chronic inflammation, that's where we will have excessive amount of transforming growth factor beta, interleukin 6, and interleukin 17. And that can lead to fibrosis. And in cancer, it can push the immune system away from Th1 and compromise the immune system. And also it can lead to fibrosis, which will prevent the infiltration of the white blood cells because of the squeezing of the blood vessels. And most of the time, this chronic inflammation that's mediated of Th17, it's part of the inflammation of the autoimmune disease. Almost all autoimmune diseases out there, they have hyperinflammation, which is Th17 inflammation. Again, we know that the renin-angiotensin system overactive of the angiotensin 2 type 1 receptor are responsible for the fibrosis and for the inflammation and the vasoconstrictor. And we know that angiotensin, when they combine with the angiotensin 2 type 1 receptor, it leads to all these things: vasoconstriction, fibrosis, inflammation, all that. But when angiotensin 2 combined with angiotensin 2 type 2 receptor, along with ACE, which ACE will convert the angiotensin 2 to angiotensin 1,7, definitely this will mediate the opposite effect. So again, renin-angiotensin system, they have two sides, right? Two kind of receptors. One is inducing fibrosis, inflammation. The other one is inducing anti-fibrosis and anti-inflammation. And again, angiotensin 2, if the receptors are the type 1 receptor, angiotensin 2 type 1 receptor dominant during the injury, during the beginning of the injury, it will be dominant. The receptors will be dominant, which is angiotensin 2 type 1 receptor. You will get the response of vasoconstriction, fibrosis, and inflammation. But during the healing, the receptor that's going to be dominant is angiotensin 2 type 2 receptor. And then you will end up with the healing stage, which is the vasodilation and anti-fibrosis and decrease and anti-inflammation, right? And cell growth. That's the healing stage of the injury. But if you continue having this signaling of angiotensin type 1 receptor due to the whatever causative agents, the insult is continuing causing the damage, like ulcer, peptic ulcer, Lyme disease, whatever that's propagation of the immune system or continuation of the inflammation of Th17 inflammation, then you would have this side of the equation of the arm of the renin-angiotensin system overactive, leading to fibrosis. See, again, this is what's happening in COVID-19, right? In COVID-19, the spike blocks the ACE2. It blocks the anti-inflammatory arm of the renin-angiotensin system. It blocks the ACE2, which will block the angiotensin 2 type 2 receptor signaling from activating and balancing the immune system here. And what would happen? You would have overactive because of the blocking of this anti-inflammatory side by the spike receptor blocking the ACE2. Then you would have overactive angiotensin 2 type 1 receptor signaling, as you see it here. And this causes RAS imbalance. It causes inflammation, fibrosis, vasoconstriction, oxidative stress. And this is what we see. And that's the reason why post-COVID-19, they will have pulmonary fibrosis, they will have cardiomyopathy, they may have liver cirrhosis, they may have damage in the gonads, right, and fertility. It's just because of the continuation of activation of the angiotensin 2 type 1 receptor and unbalanced because of the blockage of the anti-inflammatory arm of the renin-angiotensin system, which is mediated by ACE2 and angiotensin 2 type receptor, and along with MAS receptor. This is the anti-inflammatory arm of the angiotensin, as you see here. And so the spike protein blocks this anti-inflammatory arm, allowing over-inflammation due to the over-signaling of the angiotensin 2 type 1 receptor. Again, when we're trying to treat cancer, what we do, we give them chemotherapy and we give them maybe an immunotherapy, whether those antibody blockades that we're giving, or we're giving cytotoxic T cells or lymphocytes. But if you have fibrosis, the fibrosis will squeeze those blood vessels, preventing those white blood cells to infiltrate the cancer and protect the cancer, preventing those antibody blockades from reaching into the cancer, preventing those chemotherapy and photodynamic therapy drugs to reach into the cancer. So adding Losartan will help to break those fibrous tissue, allowing those chemotherapy and photodynamic therapy drugs and then the lymphocytes and the antibody blockades to reach into the cancer, destroy the cancer, as you see it here. So if I want to do photodynamic therapy treating cancer, I will add in the cocktail Losartan. I think Dr. Weber from Germany would like adding Losartan in his cocktail in photodynamic therapy of cancer. Or even chemotherapy. If you want to add chemotherapy, it's good to add Losartan in your platelets nanoparticle, along with your chemotherapy like Doxil or doxorubicin, whatever chemotherapy that you're going to do, load inside nanoparticle along with Losartan to break the fibrous, to prevent the squeezing of the blood vessel, allowing those drugs to reach into the tumor, right? Again, this just shows you that how the renin-angiotensin system control the immune balance, control the inflammation, control the wound healing, right? Because in the first stage of the wound, when you have injury, you need to have an active angiotensin 2 type 1 receptor signaling, which leads to inflammation and fibrosis and expression of interleukin 6 and 17, and all this and neutropenia to kill that germ and pathology, whatever. And then once the free radicals drops, you will have more of receptor of angiotensin 2 type 2 receptors being expressed. And then you will have the healing process of the stage of the renin-angiotensin system, which is basically that you will have angiotensin 2 receptor type 2 signaling, along with conversion of the angiotensin 2 to angiotensin 1,7, which will activate the mast receptor signaling, the vasodilation, the anti-fibrosis, the anti-thrombosis, right, and all the good stuff. And this is very important. I mean, especially if you have cardiomyopathy. I mean, treating the patient with Losartan would help a lot to prevent and treat patients with cardiomyopathy and all those fibrotic disease in general. Again, as I said here, injury, whether it's toxin or mechanical pathogens, leads to inflammation, and especially if you have over-inflammation of Th17 and you have too much of interleukin 6 and interleukin 17 and transforming growth factor, this leads to stimulation of the fibrosis, whatever organ you talked about, whether it's eye, cornea, whether it's in glaucoma, where they have this trabeculae, which is at the angle of the eye, between the iris and the cornea, that's been blocking the drainage of the fluids, or the skin, and you have keloids, or kidneys, you have fibrotic kidneys, or lung fibrosis, or liver cirrhosis, or adhesions. All of this is mediated by Th17 inflammation, interleukin 6, transforming growth factor beta, interleukin 17, and blocking the site inflammation, polarizing the immune system away from Th17, which is maybe to Th1 or Treg. I think it's better to move them to Treg. Definitely you can manage all those chronic disease. And we have a lot of peptides and a lot of drugs like low dose naltrexone, Losartan, those peptides derived from melanocyte stimulating hormone or from erythropoietin. All of this can help to block the Th17 inflammation, interleukin 6, transforming growth factor beta. Again, same thing, you know, cancer association fibroblasts or fibrosis can be activated by interleukin 6, by free radicals, by transforming growth factor beta, by the chemotherapy and radiotherapy, which causing the increase of free radicals. And this leads to the fibrotic, which change the tumor microenvironment in favor of the cancer, protecting the cancer from the infiltration of the white blood cells and from the chemotherapy and from the drug. Again and again, you know, in liver cirrhosis, I think we can manage them with ARB, Losartan as well, because liver cirrhosis is due to the Th17 inflammation, and it's due to overactive angiotensin 2, which is signaling the transcription of the transforming growth factor beta and interleukin 6 and interleukin 17. And if we stop this, stop the angiotensin 2, we may inhibit the TH17 polarization inflammation. You inhibit the transforming growth factor beta signaling, as you hear, and you may heal the liver fibrosis. So Losartan can be a drug of a choice for liver fibrosis. Now, and if you load the Losartan into IVs and you with platelet nanoparticle, we may get more this drug into the liver than the oral dose and may stay longer there as well. Again and again, I invite you, all of you, to become CDP MCS Center. If you want to sell your products, like I have some company here, they having conferences where I present. I don't know if Dr. Alprina is here. He wants to promote his conference, or Dr. Farsham, but you can promote your service at CDP MCS. You can help me to get the investors that we need to set up CDP MCS clinics. You can speak at CDP MCS if you like. You can join the fellowship program. You can promote CDP MCS, and also we will share the pie with you. In other words, we will contribute whatever. And we want you to donate to CDP MCS. If you go to my website, there will be a donating button there. I think I can show it to you here. Did you see the screen? Can you see my screen, everybody? Hello?
Yes,
Can you see my website?
yes.
Yes.
Yeah.
Yeah.
So this is my website here. Dr. Michael Beamer also helped me up to write down those little things here too. And this is the video here. This is where you click to join. When you want to join anytime, you don't even need to receive anything. Text for the next week, just click on join us, and that will take you to the Zoom meeting here. Did you see it? And then you register for the next week. Okay. And then if you say, well, let's go ahead and contribute tonight, and so we can keep this sessions going, you can go to donate CDP MCS here. It will take you to organize it, because that's what I want to do. I want to open nonprofit organization. Dr. Klatz donate $1,000 directly. And then we have Dr. Joseph, Dr. Robert Quinn, and other two anonymous donated some money there. So from $100 to $1,000, whatever you can do, just go ahead and donate, so we can keep these sessions going, and possibly we can, have this nonprofit organization for CDPM where we can offer CME. We're working on that. Right now, we don't have the for-profit with CDP-MCS, which is designed to set up clinics. But I think we need to have a sister company, nonprofit, so they can do the CME and they can do the physical meetings and all that stuff. We're working on it, me and Dr. Mike Beamer and other doctors here. So we'd like you to help us and donate as much as you can, so we can keep this monthly or weekly webinars going. Hopefully enjoy the conference, and if you have any questions, please do. Questions? Alprina, are you there?
Yeah, I'm here.
Go ahead if you
Jonathan.
want to promote your conference.
Yeah, thanks for inviting me. I'll be very quick. I know you guys been on for a long time. We have a network of functional medicine clinicians that we've been working with for over 20 years. And once a year, we have a conference for them to showcase the latest technologies. This year, we're launching the Health 100 Collective, 100 companies changing healthcare. And we're inviting practitioners to use these technologies so we can list them as a top technology HP, and they can benefit from what we call the 4x4 matrix, 4 ways that we drive patients into their clinics, and 4 platforms on how they can educate patients even before they come to see the clinician in the practice. All this is happening on the 28th, 29th, and 30th of April in about 2 weeks in Dallas. And we invite everybody to go to changelifedestiny.com. You'll see what is going on. Friday, we have about 25 workshops. Dr. Halasa will be there presenting, and we have other world-class master experts. Friday night, we have a black tie dinner. It's a by invitation only dinner where we're launching the Love Your Health movement, a movement to get society to make health their priority. And it's through that movement that we can drive a lot of patients into clinics that are using technology in their practice. Saturday, Sunday, the exhibit hall opens and we'll have the Health 100 technologies showcased so everybody can experience and learn about them and decide if they want to use them in their practice. So I invite you all to join us the last weekend in April in Dallas. You can go to changelifedestiny.com and learn more about it. And you can always contact me, Al at functionalhealthnetwork.com if you have any questions. Thanks for your time, Dr. Halasa.
Anytime, sure. I'll be there, so I wish all of my followers here to attend the meeting, so we can have a great time there, quality time, like Dr. Joseph James. Hopefully we will be there, Dr. Patel, if you like, and all of you, Dr. Cruz, and whoever left here in this room, 14 people. I'd like to see you all in physical. Hopefully we'll have our meetings and in collaboration with Dr. Al and all that. So Dr. Klaas is here too. Yeah, so I want you to encourage you to start thinking about, reforming your clinics and becoming chronic disease prevention management. If you want to donate, as I said, Dr. Klaas donated $1,000. I want to thank Dr. Klaas for that, for supporting us all the time. And we're looking for all of you if you can do that, then that will help make things easy for me to organize this nonprofit organization with the CDPM. That's what I'm trying to work with Dr. Mike Beamer. Any questions?
Dr. Halasa, can you post your website on the chat so I can copy and paste it? And I put some questions on the chat for you to answer, and Dr. Mike Beamer.
Okay, so let's go with the questions. My website.
But post your website so I can copy it. So then
Okay.
I'll know how to make a donation easily.
CDPMCS.com.
Just post it so I can
put it in
copy.
there. I'll put it in there.
Right, so that's the website. Post it, I think. It might, if you add the www, it's better. Okay, so let's go with the questions. CDPM.
Yeah, here we go. Dr. Cruz had a couple of good questions, and there were some others as well.
Right.
Let's see, where are we at here? Okay, Dr. Cruz's main question is, what is the cost of the injectable Losartan, and what is the expiration date? Now, one thing I do know is it's about, I think they were looking at 60 to 90 days that they were testing on that. I don't see that the pharmacist there, John Herr, is still on with this, so I can't ask him the cost. Now, the question, a good question, Dr. Halasa, for you, and maybe Dr. Patel or Dr. Joseph as well, if you have done this, can we inject Losartan into spinal fluid? So these questions center around spinal fluid and the
Nobody injects Losartan up to now into the epidural up to now. So that's the point. You will be the first if you do it. Okay. We have publications being injecting Losartan into the joints. Okay, so that's good. So if you start with the joints and everything is good, then you feel comfortable, you want to move to epidural, especially the cauda if the patient is having a problem, in other words, fail all the treatment, and you think that Losartan would help them, then you will be the first and to be reported that you did this. I mean, everywhere, even for the eye thing, I mean, the cornea thing, there must be a pioneer, frontier who did it. And they have some peace of mind there. They have a consent form. It's called the kind of mercy consent form. With every other treatment that's available fail, then you consider Losartan as one option. So you need to learn how to do the consent form. There's a consent form for that. And I think you can go ahead and proceed with the hard to treat cases. You may be able to help them, but there is none published article. I did not see anyone that epidural Losartan up to now, but I saw the intra-articular joints is being done, and it's easy to be. Methylene blue, don't do methylene blue in the epidural for now, because could be because of impurity of the methylene blue and end up with side effects. But for joints, it's okay. Even facet joints, you can inject the Losartan, the methylene blue. So this question, did I answer them? Okay, any other questions?
Yeah. Let's see. We were talking about the eye drops. That was 6 times per day for corneal injury and scarring. And Dr. Cruz, to your question on that, I got a private message about there is a major clinic doing a Cleveland clinic is using Losartan in the eyes. And I'm trying to find the name of the clinic. It's a Dr. Cole at Cleveland Clinic. Cole Eye Clinic at Cleveland Clinic is where they're, the research and things is going on with the eye drops. So that could, so if you maybe were looking at that.
Yeah, Dr. Halasa, how long were those people treated, those cases that you mentioned, for 30 days, 60 days for the corneal burn or the
They did it for
scarring
1
after-
month, I think. One case, the case is 1 month, and they see good results. Some of them 15 days, and they saw clearance.
Okay.
But they are looking to, they are telling to us to do it even 6 months, do it more, so we can get even more clearance of the cornea. Right?
Huh.
And there's no toxicity in the cornea because did you see they already put it on the normal eye and there's no problems at all. And Losartan, it's FDA approved. The safety, it's we know it's completely safe. So, and I think if again, you can get it from the compounding pharmacist, and the compounding pharmacist, and I think it's good for glaucoma as well. So there is articles about using it for glaucoma, open glaucoma. That's a big thing. And that's where Dr. Patel, I'm trying to get her husband, who is an ophthalmologist, to start using it for glaucoma and see if it's dropped the blood pressure of the eyes, and or that would help to protect the retina from the pressure from damaging. That's a big thing. I mean, right now the cornea, there is publication about glaucoma which worked, which is working, but we need more clinical for that. And for today, really, I want to get the doctors to do the epidural, or at least start with the joints and see what we can come up out of that.
And do you think with the epidural that you have to mix? Well, first of all, I've done like a sweet caudal, which is just D5W into the caudal space, and I've gotten reasonable results with that. But arachnoiditis is, I think, fibrosis and inflammation from people who have too much surgery or too many epidurals, and the steroid gets into the spinal canal and creates inflammation and fibrosis. So my question to you is, should we try to put Losartan in the epidural space, or should we try to put it in the spinal fluid space, intrathecal, to try to help somebody with arachnoiditis? I've never had...
Arachnoiditis, I don't think, I think it's just enough. When you do the cauda when you do cauda equina, you're not getting intrathecal.
Right,
It's
but
in
I
that
haven't had
area,
much success
in the
with the sweet caudal, some, but not. So that's why I was asking, where do you think the Losartan
I think
should go?
just start. I don't want to go more dramatic here. Okay, let's start step. It's more
Epidural
safer.
before
Yes.
spinal.
If you start,
Okay.
if you say I want to do it epidural, it's more than intrathecal. Intrathecal is more, let's start with step by step. Start with the regular joints. And if you're comfortable, go with epidural. And if you feel comfortable, then you can go to intrathecal. Like right now, just go epidural, because Losartan and small molecules will diffuse in and get into the intrathecal, right? And so you do just the quad equina, and I will not do more than getting 5 milligram of
Right. And
Losartan,
and if you do an epidural, do you think you have to do what you were saying, mix
yes,
it with
it's better if you
PRP?
load them inside the nanoparticles. You remember
Okay.
what they're doing? They have a vehicle that keeps it Losartan, long lasting or slow release. Platelets nanoparticle, it gives you that peace of mind that you're injecting the platelets, and those Losartans being wrapped, and their release are slow, I think, and it stays longer. So and then you add procaine instead of lidocaine. Procaine has anti-inflammatory regenerative effect. Procaine, I like procaine versus lidocaine. And then you add NAC and acetylcysteine to buffer the redox. It's good to add NAC in your equation. And I think
How
with
much
this,
NAC?
And acetylcysteine.
Yeah, NAC. I know for IV we use 100 milligrams. So if you just do 10 milligram of NAC, okay. 5 milligram of Losartan, and load inside the platelets nanoparticle, add the procaine, Okay, and add, if you want to add hydrocortisone, that's fine. If you don't want, that's okay. Because hydrocortisone is not like the steroids that we're using, right? For the epidurals. It's physiological steroids. If you
Got
want.
you. Yeah, thank you.
Keep
Very
yourself
helpful.
in a very light,
Right.
biologically friendly drug. I think that's the best thing to do. Okay. Any other
Thank you.
questions?
Yeah, I have
Welcome.
a quick question. So like IV Losartan loaded with nanoparticles, say we're not using methylene blue, then, the way I see it, 5 milligrams, that's a very low dose of Losartan compared to 50 milligrams.
But 50
you know,
milligram, you're taking it orally, right? You remember that? And oral,
Yes.
you don't get the whole absorption. You may get 10% of the absorption, not necessarily the whole thing. Then you start with 5 and you go up because you want to check the blood pressure. There is all the time boundaries there. If the blood pressure is okay with 5 milligram, you can go to 10 milligram and still check the blood pressure. So don't go like high in the beginning for many reasons because there is a blood pressure there. Unless you want to give oral methadone.
So the idea then is that it may not have the same effect on the blood pressure if the nanoparticles are going to areas
Yes,
of
that's
inflammation.
possible, but
and
I
not-
will start with low all the
but-
time. Start 5 milligram, and then if the patient is good and all that stuff, then the next time do the 10. And then
Okay, and then
you can go.
maybe we want to use like red light and shine it on the area that we are trying to treat, especially if there's chronic scar tissue. There may not be much inflammation going on, like acute. There's no like real acute inflammation that would attract the nanoparticles. So I would think we would want to shine the red light maybe to create some heat and an initial little burst of oxidative stress that will attract the nanoparticles. Is that sort of the?
All the time when you have chronic inflammation, light therapy is not a harmful thing. It just helps to balance the immune system, the redox and all that stuff. So
I'm saying using the red light to direct the nanoparticles where to go.
I think I agree with you. Either any form of energy, electromagnetic waves, light therapy, anything as an adjuvant energy form, along with your platelets, along with what you're doing with loading all those drugs, I think you can get better effect than use by itself. I agree with you 100%.
Okay, all right.
Any
I
other
have a question,
questions?
Doc.
Yes.
Yes, I have a question, Dr. Halasa. We have an FSHD patient. He's lost most of the muscles of his hands. And he was, prior to this, when he was younger, he was a piano player and a very good one. He would like the use of his hands back. And I think we would start with the fingers and the hands and then move our way up. But we have to limit trauma to the muscles, what little muscle he has left, in trying to get rid of the fibrosis. And I was wondering if there's a way that we could do this with a cream on the hand rather than injections into the hand. Is there a vehicle whereby it could absorb into the hand and take care of the scar tissue that's surrounding the muscle and not cause too much lowering of the blood pressure?
Yeah, Mike Beamer will do it. There's no problem, I think, compounding formulation that get into deeper tissue. He has the vehicles for that and possibly will add more other drugs for scarring tissue there. Again, there is articles and publications about muscles that's being injured, and they use Losartan to prevent the fibrosis and helps the regeneration of the muscles. Because once you have muscle injury, any muscle injury, even traumatic muscle injury, what would happen is that the fibrosis will take a place and replace the muscle cells. And
Right.
what they're proposing is adding Losartan to prevent the excessive fibrosis taking a place and allowing the muscles to take a place in regeneration. So I think this Losartan topical, again, start with 5 milligram topical and then go above that. And Dr. Mike Beamer, I think he can create a topical cream. What do you think, Mike?
Yeah, there's no problem with that. It's just a matter if it works or not. It's not something that's
Yeah.
been tested, but it's not hard to do and it's not expensive to do. So like you say, I think what I would do is and I'd be happy to do this for free for you, but we could make a test solution and put it on and just put on a 5 milligram topical dose each day to test it and just see if you have any blood pressure changes.
That would
So
be
that's the
wonderful.
first, you know what I mean? But I'd be happy to provide that to you, and and I'll do the same thing. I'll put it on. My blood pressure is probably 5.7 points high, so I could probably put it on, see if it reduces it any or something. But we should check that first and see. But yeah, there's no problem with doing a topic.
Yeah.
It's just a matter whether we have side effects before effectiveness.
Yes, yes, yes. Thank you.
Yeah.
Nice. Okay.
Yeah.
Okay, any questions? Everybody's happy here? Are you all happy?
Yeah, he put in here.
Oh,
Yeah,
okay.
but I was thinking,
Yeah.
yeah, that's what.
So I do, maybe possibly
Yeah.
next Monday, if nobody's gonna speak, I may be speaking about this peptide, which Dr. Patel, she triggered the whole thing, which is the melanocyte stimulating hormone derived peptide. It's called the KVP. If there's anybody who could present, that's fine. But I want you to help me up to get more doctors on the board by joining LinkedIn. And then when I post the invitation, if you can repost and make your comments, they will stay longer and you will see more reaction there, and possibly we can fill up the room to 100 doctors. That's the goal. The more doctors we have, the better that we can redefine medicine and advanced medicine, because we need their feedbacks and their results, like we are hearing from Dr. Patel and Dr. Juicy, from Dr. Cruz. And the more opinions, the more validations that we can get. And we need more doctors in this room. So I'm looking to get it to 100. Right now, the max we got it to 30. Days we got 40, but we need to get 100. So can you help me up? And when I send you those invitations, join LinkedIn and just be interactive there and involved in inviting your contacts and people, and meet me at the conference that's going to happen in April, end of April. And also we're going to be in A4M, plus maybe possibly we're going to be in June with Dr. Fasha. We'll see. So any questions? Everybody's happy? Good. Okay, we'll see you Monday. Take care, everybody.
Hey, great job, Dr. Halasa. Thanks, everybody.
Bye. Bye.
Thank you.
Thank you.
Thank you, Dr. Halasa. Good job.
Okay, take care.
Did
See
you post the website, your website
Yes, I
in the
did.
chat?
I did.
Okay.
Okay, take care. See you,
Yep.
everybody. I'll text you as well. Okay, bye.
Bye-bye. I mean, to me, he's